online, and this committee is brought back to order. Our next issue is DD waiver program, and we're going to first receive testimony from Director Johansson. So Director Johansson, if you please come forward. Welcome to the House Appropriations Committee meeting in Du Bois. We appreciate your attendance.
Good morning, Mr. Chairman, Mr. Co-Chair, members of the committee. Stephen Johansson, I'm the director for the Wyoming Department of Health. Really great to be with you this morning. Beautiful morning in Du Bois. I'll keep my comments brief, but Elizabeth Forsland is here with me. She is the manager of our Home and Community-Based Services section in the Department of Health, which oversees the DD waivers, as well as our community choices or long-term care waivers. Mr. Chairman, I thought it might be beneficial just to briefly recap our discussion in Gillette at the last meeting. We did provide a follow-up memo answering more specifically some of the questions that were raised. You should have that in your committee materials. I won't go through every item there, but again, happy to answer any follow-up questions that the committee has. I've had some good discussions with several of you offline on some more nuance and detail around some of these policy areas. But essentially, to summarize at least our testimony from the Gillette meeting, we had presented this area of the Department of Health, the DD waivers, and the policy issues surrounding them in kind of three dynamic ways in terms of options for the legislature and the committee. One is funding the wait list. Our wait list currently stands at roughly 389 as of today. And those are individuals that comprise adults and children. So funding the wait list is always a policy consideration for the legislature. Secondly, there's a lot of discussion about provider rates. And of the approximately 500 or 600 providers in this particular area that we have in Wyoming, rates are important. When you fund folks off the wait list, you certainly want available providers to be able to serve them. And we have a mixed bag of types of providers around the state. You have larger providers, some of which you heard from in Gillette. I believe you toured a provider in Riverton yesterday. You also have very small independent providers. And in fact, half of those 500 or 600 providers around the state serve less than 3 people. So again, very different, business models, very different scale, different infrastructure needs, et cetera. But those first two dynamics of funding people with budget off of the wait list can act in concert with or sometimes be in tension with provider rates. And so those are things that as we work with this committee or answer your questions, develop options for you, some of which we gave you in the follow-up memo, would just encourage the committee to consider in any appropriation. I think both of those items should be a part of that discussion. Getting people who have been waiting sometimes for a year and a half or more, budget to provide respite to the family, to provide direct services, et cetera. And then secondly, provider rates are absolutely very important for this type of service delivery. And the third item that we had presented on, Mr. Chairman, in Gillette goes along with both of those, which is emergency needs. So folks on this program, individuals that are served on this program, week to week, month to month, year to year, those situations can change. Housing situations can change. Behaviors can change. Acuity level can change. And so we had given you an overview of what we call our Extraordinary Care Committee or our ECC process. And that's a way that individuals through their case managers can apply for emergency funding because the situation has changed or there's a dire need that the state, the Department of Health needs to consider as it pertains to their services and as it pertains to their budget. So again, Mr. Chairman, just to recap that or summarize what we talked about in Gillette, I think if this committee or the legislature were to entertain new or additional funding in this particular program, that those three items would be top of mind, at least for your Department of Health director, in terms of considering folks on the wait list, but also being thoughtful about provider rates. And third, with emergency needs and things that change over time with this particular population. Very quickly, Mr. Chairman, just to update the committee, we had provided some numbers for you in our follow-up memo. You had asked, what do you project the wait list to be if we're considering the 2027, 2028 budget cycle? And right now, as Ms. Forsland whispered into my ear, we have 389 people on the wait list. We projected that about a month and a half ago, as of July of next year, just projecting the growth, modeling the growth, to be over 415 individuals. So that's probably going to be closer if all things were equal, given the enrollment we see now, probably in that 400 to 450 range. And the reason I mention that is you all have difficult policy decisions to make across the state with all of the budgets. In this particular area, we're absolutely more than happy as we go into our budget hearing, go into the next session to give you our best numbers of what July 1st of next year looks like so you can make those funding decisions as you see fit. But what we had provided you is if you were to make the decision on that projected number of, let's say, 415 people that we anticipate, if nothing else changes, would be on the wait list as of July of next year, that would require approximately $24.9 million on the biennium to serve those people and on what we call the supports waiver. And that's what we fund people off of the wait list onto the supports waiver. The number, easy math for you, is we anticipate around $30,000 per year per individual for the supports waiver. And so you multiply that times 415, you get that $24.9 million biennial figure. Half of that would be state general funds, so about 12.4 million. Half of that is matched with federal funds, federal Medicaid funds. So all of these total numbers that you see.
Chairman?
Mr. Johansson, one moment, please.
Yeah.
Go ahead, Mr. Co-Chair.
So, Director Johansson, both of you, thank you for being here today. Appreciate it. So, sorry to interrupt you, but now we're getting into the meat of it. So, are you telling? I just want to make sure I understand the 24.9 million. Are you testifying then that would reduce the waiting list to zero? Is that and I guess I just want to get on the same facts that you are.
Director Johansson.
Mr. Chairman, thank you. Chairman Salazar, yes. Just to remind the committee what we talked about in Gillette, that would fund what we anticipate the wait list to be right now.
Okay.
When you fund everybody, you essentially say we're going to get the wait list to zero. Just remember that's a point in time, and that wait list would then start growing again.
Okay. Co-Chair, follow up.
So when we took, thank you, Mr. Co-Chair. When we took the tour yesterday of the community entry services, comment that was given was that I asked those folks, what would it take to, reduce the list? And the response was, well, we don't look at it that way. We look at it in terms of how many employees we have, and then given the number of employees, that determines how many people we can actually bring into. My question is, do you agree with that? And second of all, do you stick with the 24.9 that will reduce the 350 of the 415 to 450? Will that take care of the list?
Director Johansson.
Mr. Chairman, Co-Chairman Salazar, yes, but let me clarify, because the reason for mentioning these two dynamics within this program, one is wait list, the other is provider rates. And the provider you toured and heard from, absolutely, when you're running an organization like that, all of your capacity is dependent upon the staffing that you can have to either operate at 100% capacity while all of your beds or slots are full, or if you're understaffed, then you have to take that into consideration. The numbers I'm giving you now would be specific to just providing budget to individuals to come off of the wait list. That has to work in concert with those individuals coming off the wait list having available providers. And so provider rates, that second kind of dynamic there, becomes an important part of that discussion. And there are both larger scale providers and independent providers around the state. And it's very unique to the individual's needs, their communities, of what they would have access to. These numbers are specific to saying if you legislature wanted to provide support waiver budget right now for everybody on the wait list, that would provide them an individual level budget for services, not necessarily tackling that provider rate
Right.
question.
Follow up, Mr. Co-Chair?
Yeah, thank you, Mr. Kutcher. I've got a lot going on in my mind here. So the 450, there are different levels on the wait list of priority. Even with those added, obviously it's more expensive with the more challenging that the 24.9 would still cover everything then. And then the other comment that you made, well, it's dependent still on reducing the wait list, depending on whether those providers can hire people to actually take care of that. I'm assuming that wait list then draws down only as quickly as the providers are able to find qualified people to then match the list. Is that correct?
Director Johansson?
Mr. Chairman, Co-Chairman Salazar, yes, I think that's very important. But again, I would reiterate that these individual folks or cases on the wait list can look very different. The math that we're providing today and that you saw in the follow-up memo is what we call the supports waiver. And that is what we fund everybody off of the wait list first onto the supports waiver. And again, we look at it around on average $30,000 per year. The process to become in the higher tier, as you mentioned, where you have additional needs, that goes through an extraordinary care committee where we look at additional comprehensive services. These numbers are specific to the question that was raised, rightfully so, last committee meeting, to say for folks that have been waiting, individuals and families, for a year and a half. Right now, we're below 18 months, but we're approaching 18 months average wait list. Would be to provide that type of support service, which includes individualized care, respite for the family, a host of services to provide relief and support for that individual and for that family. That's the first dynamic here. And then I really encourage us to consider two approaches that I think we could blend and get to my last point here shortly, where then provider rates, you'll hear testimony about the need for additional rate rebasing, those types of things. I know I was a little bit squirrely last time in Gillette because we were so early in the budget development process, and that's still the case. We have not submitted our budget proposal for the 2027-28 biennium to the governor yet. That will come in the next couple of weeks, and obviously we'll have hearings with him and work with him. But we have, and you will see a budget request from the Department of Health that we hope marries these three concepts together, both in terms of waitlist funding, some amount of provider rates, and also emergency care for those cases that we're talking about. That is in our draft budget request, Mr. Chairman.
Mr. Co-Chair, with your.
Go ahead, Mr. Co-Chair.
So just a comment more than anything. It was very important. I'm glad we took the tour yesterday. The need is definitely there. And I can only speak for myself. The need is so great, in my opinion, that this committee must do something about it. And so, again, I am committed myself to make sure that we reduce this waiting list. It was very insightful yesterday when you're actually talking to these folks, and even the ones who weren't there because they're still on the waiting list. And so this is a need that needs to be addressed. And I think you're going to find support on this committee to do something with regard to this issue. Thank you, Mr. Chairman.
All right, Senator French, and then Representative Pendergraft.
Thank you, Mr. Co-Chair. Would you run over that again for the biennium, the cost 24.9 million? You said, which percentage was the federal, and then a follow-up, Mr. Co-Chair?
I think it's 50-50, but Director Johansson, confirm that, please.
Mr. Chairman, Senator French, yes, typically our match from the federal government is 50%. So the aggregate figures for the state general fund component, you can divide in half. So that 24.9 million on the biennium would be approximately 12.4 million state general fund.
Follow up?
Yeah, thank you,
Senator
Mr.
French?
Co-Chair. So on a yearly basis, it'd be $6 million or something like, and change is what we're looking at. Is that correct?
Director Johansson.
Mr. Chairman, Senator French, that's accurate. One caveat that, this is point in time now. What we provided in the follow-up memo was what we were projecting, essentially 2 months ago. That would just request the flexibility as we approach the budget session to provide updated numbers to the best of our projections at that time. That could be up or down depending on what we're seeing in enrollment in the program.
Representative Pendergrass.
Thank you, Mr. Chairman, and thank you, Mr. Director, for being here. It's good to see you again. You'll recall that last time we spoke, you heard my testimony, and I spoke about sacrifice that my family had made, that churches had made, and others in order to do what we felt was necessary. I expressed my interest and support in the DD waiver program. I think it's a valuable thing to do. And I made what might be kind of an unusual request of you to have a little bit of introspection to your agency and see if there might be some sacrifices that you as an agency could make. And so my question is, are we going to see in your proposed budget coming up any reflection of that? Were you able to find anything that perhaps would help us out with this?
Director Johansson.
Mr. Chairman, Representative Pendergraft, again, it's a good question, and I absolutely respect the intent of it. As I mentioned in Gillette, I think that's absolutely possible. But at this scale, keep in mind this program right now in our Department of Health budget is over $300 million on the biennium currently. It's a large scale, very expensive program because these services and the acuity of some of these clients is very high. Similar with our nursing home funding for our elderly populations on Medicaid. What we would be looking at to offset would be significant program reductions in other areas. We absolutely, can have options. They come with consequences. In terms of finding administrative dollars that could support all or a significant portion of this request, quite frankly, it's difficult to find it at that scale in the department. 92% of our dollars go out the door in the forms of these types of reimbursements. And that remaining 8 or 9% of admin and overhead, the vast majority, 90% of that is at our 5 direct care facilities like the state hospital in terms of the staffing. Representative Pendergraft, you certainly have my commitment if that's the direction of the legislature to fund items like this and the will of the body in the legislature to fund it through offsets. We're certainly at the table to prepare those. But I do think it's important to note that it involves reducing services or coverages or reimbursements in other areas. And that's a different conversation than, finding float or money that can be freed up with minimal impacts. It's really about, should we cover or not cover certain types of services, eliminate certain types of programs. And that's just a different direction than finding this sort of administrative float, if that makes sense.
Okay, Senator Larson.
Thank you, Mr. Chairman. I don't know if you can answer this. In your opinion, do you think there is personnel out there to, if the dollars were there, that the providers, are they there, that they can find them?
Director Johansson.
Mr. Chairman, Senator Larson, I'm endlessly frustrating this committee. It's a mixed bag. There are providers with capacity. There are providers that are at capacity or completely under capacity because they're struggling to find staff. In Health and Human Services right now, especially in these types of settings, whether you're running a facility for developmental disability populations, a nursing home, an assisted living facility, what you'll hear from your constituents in those businesses is we can't find staff. Department of Health is no different. We are really struggling at our safety net settings like the state hospital, like the veterans home, to find CNAs and to find nurses. In this particular case, we would call them DSPs, direct service professionals. It's difficult. It's difficult to be competitive with other industries. But you do have providers around the state that have capacity. There are, when you fund slots open on the waiver, there are providers that can provide that service. I can't say it's uniform across the state because it really is quite variable. But two things, Mr. Chairman, if I may, that I think are important just with the economics of this. Funding individuals, in this case, hundreds of individuals potentially off of the wait list, that does have a market creation mechanism where the budget's there. Not saying it's direct one-to-one that someone gets a $30,000 budget for their loved one and suddenly there's a provider that pops up, but it's certainly having that volume creates over time service delivery that's there. But it must work in concert with the second component that we talked about, which is how does the state of Wyoming fund the provider rates, the reimbursement rates, specifically from those budgets. Waitlist is one thing, provider rates is the second. And like I mentioned, can't tell you exactly how it will shake out with the governor's recommendation come November for the budget, but we have prepared a request that we hope marries these concepts together. And with, if I may, Mr. Chairman, with options, and I want to be very clear, you as a committee and the legislature in general, you absolutely have options. It's not one or the other. You could fund the entirety of the wait list point in time. You could prioritize and say for individuals who have been waiting over a year, we're going to prioritize that. Or for individuals who have been waiting over 6 months, we're going to prioritize that. So I don't want to come off from the department as saying you either have to do this or nobody will get services. There's always options and tiers within these proposals, including within the provider rates of what the legislature would want to prioritize.
Follow up?
So, Mr. Chairman, sorry, can you remind us on the provider rates? What was the dollar amount on that? It's slipping my mind.
Mr. Johansson, before you do, because this funnels into my question, of the 24.9 million, you said that some of this was going to be, and you mentioned that it's going to provide options for us as far as provider rates. What portion of the 24.9 million would be directed for increasing provider rates? And then to answer his Senator Larson's question, what would you anticipate those provider rates being on average after this increase?
Mr. Chairman, really, really good question. So to clarify, the 24.9 million we are mentioning this morning is only for funding individuals off the wait list under the current provider rate mechanics with no changes to that. If the legislature wanted to consider what was the previous provider rate study that was provided last year and that you heard testimony on in Gillette, that is a separate conversation. But again, I think these two could work together depending on the will of the legislature. The 24.9 million that we're talking about today is specific to providing support waiver budget to everyone on the wait list within our current provider rate scheme, not with any changes to that. What our budget request is attempting to do, and again, I know it's draft and can't tell you how it will look this fall, but it is in there, combines waitlist funding, provider rates, and extraordinary care committee or emergency funding. So I think hopefully that answers some of your question. This is specific to just taking care of the waitlist.
Okay, I think I'm going to attempt to get some clarity for you. So the first comment I want to make is that yesterday we received testimony from a provider that their average rate is $16 per hour, average. They have entry level at $15, and then some people that have worked for decades for them are, higher, but the average is 16. And I'm going to make a comment about hiring people in general, because I've written plenty of payroll checks myself. Money isn't the only answer. And what I saw yesterday is pretty clear that when you're hiring these people, they have to have a passion for this type of job. It is something where you are dealing with all kinds of personalities that are far from what we anticipate in the general public. And so that can be very wearing, and it takes a person who's truly committed to this type of care. So money alone is not going to solve that problem. And another comment that I heard yesterday from a provider, and it was very impactful to this discussion, is that they had 9 fully funded personnel, patients that they were not bringing into their organization because they didn't have the employees to service them. So in answer to some of these complicated questions, first of all, there has to be a populace that's dedicated to doing this. Money could help, but it's not going to be the only answer. And that hurdle has to be dealt with simultaneously dealing with the funding of those patients. 24.9 million, as I hear right now, does eliminate the list, but that creates new questions. I asked the providers yesterday, what is the impact of people from other states when they see that we're eliminating our waiting list completely? When I see that the estimate from the agency is that we're going to move from 389 to 415 in the next biennium, that's a 6.7% increase. I don't think anybody's anticipating a 6.7% increase in our population generally. So I'm going to ask the testifiers, how did you come up with 6.7% increase in the next biennium? And if that's the case, what is it really going to be? Because as we provide more funds, we could create a real problem for ourselves as people move to the state of Wyoming to receive these kind of services, because we want to take care of every single person on the waiting list. So there's, we're going to have to address that in some way. But to your point of 6.7% increase from 389 to 415, what motivated you to come up with that estimate?
Mr. Chairman, a couple of things there. If I can, just one item on your previous point, which is I need to make a distinction between the wages that providers pay and the reimbursement rate that's offered. So again, the rate study that was completed last year, we do that per statute every 4 years, assumed in the reimbursement model that the wage for a direct service professional was just over $20 per hour. I think it's, again, important for the committee to consider what should be, if any, the enforcement mechanism on that. Is that going to staff? And that's not meant as any sort of slight against the providers. We operate 24/7 facilities in the Department of Health. It is difficult, very difficult to find staff and to work within the allocated budget as well. But there is a distinction between the reimbursement rate, the rate model that comes from the Department of Health, and the wage that a provider pays staff.
On that, I'm going to interrupt you for a moment because this is very poignant to that comment. The reimbursement rates, I'm assuming that they also include any fixed costs that these providers have. I mean, we went through a facility yesterday that was a substantial building, a lot of fixed costs that I saw, and I assume that they have to provide those out of the provider reimbursement rates that we're talking about. Is that accurate?
Mr. Chairman, in general, yes. Let Ms. Forsland address kind of what's in the rate itself based on the studies that are completed and the survey of provider data and financials that we receive. But a real quick note that, and had a discussion with a few of you offline since our meeting in Gillette, this is a different reimbursement model than, say, when Wyoming Medicaid Department of Health reimburses hospitals or nursing homes. As you all might remember from Gillette, hospitals and nursing homes are required to submit to the federal government what we call cost reports, very detailed cost reports. And there's a lot of reasons for that, to determine what allowable costs are, how Wyoming Medicaid is comparing in its reimbursements to Medicare, or that what we call the upper payment limit federally. A lot of complexity there. But essentially, we don't have that in this system. With provider cost reports. And you've heard some providers testify that, happy to provide financials, et cetera. And I think that's a great thing. So I do think going forward, longer term, even beyond this next session, potentially considering ways to make the provider rate study and those rate rebasing reports that you get easier by potentially looking at a random sample of audited financials could be something that we could discuss with the committee at your next meeting or going into the next session, where some of that cost would be much more specific in the types of reporting we get. But Mr. Chairman, I'll let Ms. Forsland address some of the rate model questions you had.
Ms. Forsland, we're going to have you testify because I'd really like to get a better grasp of that answer, but I do want to briefly make a comment here that we spend a lot of money on studies, and I believe the last study was ignored. So I'm very hesitant to fund additional studies. It's pretty easy to look at what other states are doing in this world, this realm, and assume that rents or mortgages and costs of doing business are similar. We can adjust for Wyoming costs versus South Dakota, for instance, without spending hundreds of thousands of dollars on a new report to tell us that we need to provide more funds or less funds. Less funds seems highly unlikely in this particular area. So I would not be interested, and I hope the body is not interested in additional studies just to determine what our action should be. But I'm still interested in Ms. Forsland. I want to hear from you. What are we anticipating for increases, and why do we anticipate that? Because if we're going to apply $24.9 million to eliminate our waiting list, I can foresee unintended consequences. And I want to make sure that the agency's also anticipating that as they make recommendations. Ms. Forsland, please introduce yourself to the public and to the body and let us know your thoughts.
Great, thank you. Chairman Bear, Elizabeth Forsland. I'm the Home and Community-Based Services Section Administrator. That big mouthful means that I oversee the administration of the comprehensive and supports waivers and also the community choices waiver. So a lot to unpack there just with your last comment, Chairman. I would just like to state, first of all, to answer about what's included in the current rate buildup in the studies that we conduct. And we do conduct those every 2 to 4 years because we are statutorily directed to do that. And so we are required to do that piece of the study element. And so those costs do come primarily from Wyoming providers. So right now, we survey providers to determine what their actual costs and actual expenses are in providing those services for Wyoming citizens. And then the folks who have a lot more information than me or a lot more skilled than me, the folks that we pay to do those studies also compare those to national data. And so that's what's included in those reports. But elements, as you all saw yesterday, I'm sure as you heard from testimony yesterday, last time, and you'll hear from testimony, I'm sure today from providers, what is paid to direct staff workers is not the only expense that providers experience. And so each one of our studies looks at both direct care costs and indirect care costs. And that's part of the reason that we have complicated and complex formulas and analysis in these studies. So those direct care costs include elements like wages. They include assumptions like a healthy benefits package being paid to those direct service providers and supervisors. It includes things like training, vacation, paid time off that staff members would need. And then also non-face-to-face time that is required to deliver the service, such as supervision, costs and things like that. The indirect care costs are things, Chairman, that I think that you were referring to. Those are the administrative costs associated with delivering those services. They might be costs for things like fleet vehicles for providers who transport people. They might be property taxes for folks who own properties, and other types of facility space, activity supplies, and those pieces and elements. And so those are included in our rate studies as elements for each individual service that we cover as a part of that reimbursement methodology. I would also offer that we absolutely should be looking at what other states are doing. One of the challenges with this particular, with waivers in particular, and looking at other states, is that it is not a one-to-one comparison because waivers are specifically a Medicaid service that is optional and not mandatory like your other Medicaid state services. So how those optional services have grown up from state to state have varied quite widely over the years. And so not all of the same services are offered, not all of the same types of individuals or diagnoses are covered in other states. And so there is, I know every program wants to say that they're special snowflakes in every way, but I think that that is one of the challenges or the hurdles that we can definitely address if we would like to in the future about looking at studies and what other states are doing. We do definitely look at what other states are paying, but it is hard to do kind of an apples to apples comparison.
Mr. Co-Chair.
Thank you, Mr. Co-Chair. So Director Johansson, I appreciate you talking about the wait list 24.9. And then we're dealing with a completely different issue, which is provider rates. A couple questions. First of all, can you brief me on these provider rates? What is the current provider rate? And then I guess we're waiting in anticipation because I would love that number, but I guess I'll wait. There is a residency requirement, correct? There is a residency requirement. So I'm assuming, and I'm going to guess it's a year, but maybe you can correct me if I'm wrong, with regard to any type of influx that there would occur, seeing that the state legislature wants to correct the waiting list. But without obviously giving me confidential information, can you give me some help on the provider rate as it is now? And then if it was the interest of this committee to do the 24.9, would that affect the provider rate? Can you help us out in that area?
Either of you can answer. Either of you are capable of answering that, please, Ms. Forsland.
Mr. Chairman, Chairman Salazar, the provider rate is also difficult. We can provide you absolutely the table of what each individual rate is paid to a provider. But the overall, there is not a singular rate because there are so many different types of services that fall under the DD program umbrella. And so many different types of services that one individual can be receiving. A residential service, a day type service, a companion service, are all different service elements and different costs go into delivering those. So when we do a study, those are taking all of those rates into account and giving you a cost to fund the rate study. And so those rates would increase by different percentages. So I can give you the dollar amount to fund the rate study, which would be that increase, but wouldn't be able to say for adult day services off the top of my head, this is the rate that it
Right.
is now and what it would be.
So,
Mr. Co-Chair, go ahead.
So, Director Johansson, when you testified just a few minutes ago that you were anticipating possibly a change in what the recommendation would be to the legislature, not only on the waiting list, but the provider rates. So you are dealing with a potential future number on the provider rate if there was an increase in the wait, if we were to look at reducing or eliminating the wait list, correct?
Dr. Johansson.
And then I'd like to hear about the residency requirement.
Mr. Chairman, Co-Chairman Salazar, simple answer, yes. What we are not including comprehensively in our budget request is the rate study number that came out in 2024 in its entirety. What we are blending in a budget request that we think prudent because of the discussion of this committee during this interim period is a combination of funding folks off of the wait list, in addition to specific provider rate elements that we would request to increase, but not in the sense that was provided in the rate study, if that makes sense. Can address the question very briefly. Yes, we have residency requirements in Wyoming Medicaid, but to Chairman Bear's point, we're always sensitive to what could be over time, maybe not immediately, individuals on any program in Wyoming or Department of Health, where that attraction is there from other states. And if you look at page 5 on the follow-up memo that we sent the committee, and these are just estimates from a national organization, you can see the estimated wait list of similar types of folks in other states, where they're in states like Colorado or Nebraska, Montana are over 1,000, in some cases, several thousand people on the wait list for those services. Whereas in Wyoming, right now around 389, 362 a couple of months ago, much lower, but still a concern. Chairman Salazar, as we've talked about before, one of the most difficult parts of my job, our job, is when families apply for service and have a significant need, and we have to project it. It might be 12 to 18 months before there's a slot open to fund. So not trying to indicate that these numbers have any sort of value in what it ought to be, but it's a real mixed bag across states where you have some who have funded their wait list to zero and continue to do so, and others who have significantly accumulated wait lists. But we do have residency requirements for that, and I'll certainly let Ms. Forsland add any detail if she has it.
Go ahead, Ms. Forson.
Thank you, Chairman. Just one other element that I would add to that is the rate study that we conducted back in 2024. The reason that those rate studies come up so frequently is that those rate studies have a recommendation to the legislature to fund, partially fund, not fund those studies. And so that the legislature, you all can obviously make the determination to fund partially or not fund those studies. Over time, the Department of Health has usually not included funding or not funding those studies within its budget. It has instead depended on the legislative body to make those determinations. And so that's the reason that our testimony today is about including provider rates as being an important and essential element, but not saying that this is what within our budget request those provider rates would look like.
Okay, we're going to go to Senator Guru, Representative Angelos, Senator Larson, and then co-chair in that order. So Senator Guru, please.
Thank you, Mr. Chairman. Good morning. Just wanted to ask.
You are muted.
Whoop. Sorry, can you hear me now?
We can.
Hello? You can? Okay.
We can hear you.
Thank you. Wanted to ask on question 5, since I'm the one that asked it, about providing data on waste, fraud, and abuse. Says 39 cases were initiated. In 29 cases, providers were deemed to be in compliance and no waste, fraud, or abuse was identified. The remainder 8 are ongoing, and 2 settlements have been coordinated with the medical fraud unit. I want to ask about those 2. I know I can't ask about the 8 that are ongoing, but the 2 are concluded. The $132,550.63 that was remitted back, was that, how much of that was what was deemed as claimed? Was that the total amount of the claim where all monies were covered? Or was it a portion thereof? Can you just give me a little flavor on that?
Dr. Johansson?
Mr. Chairman, Senator Guru, don't have the specifics in front of me, but in general, how those work is when a settlement is reached, that is both an administrative and a legal process that determines an amount that the department will ultimately claw back from a provider that, and I need to be clear, waste, fraud, and abuse is kind of a pejorative term. These can also be administrative errors, documentation errors, services that were billed incorrectly. It's not necessarily malicious or the type of fraud that term garners. But when those settlement agreements are reached, there's often a payback period in order to, not put good providers out of business. Those can happen over years. Mr. Chairman and Senator Guru, generally speaking, half of that recovery belongs to the federal government. So we can certainly get more specifics on cases like this that have been adjudicated, but hopefully that gives you a general sense of how those recoveries work.
Mr. Chairman, if I can
Follow up?
follow up. Yeah, no, and I thank you for that, because that's what I wanted to highlight, was that sometimes, and I've been involved in a couple of these cases where things got just uh, inputted into the system as far as what it was and what it was being costed out for. And so, and through no one's misdeed, but it just through just misapplication. And then it was found out and then corrected. And that is as much of those as there are those of malicious intent, which, as you can see from the numbers, is very small when you consider the total cost of that program over those 2 years. Would that be a fair assumption?
Mr. Chairman.
Mr. Johansson, go ahead.
Senator Guru, very, very briefly. Yes, I think that's a fair assumption across the board. And I would just note that there's several ways to both track and claw back waste, fraud, and abuse, like you're seeing here in these numbers. We really try to also focus on the front end with the types of rules, regulations, authorizations that we have for services to try to prevent providers from getting into this scenario, especially those that might be inadvertent, administrative errors where services are being delivered or billed incorrectly. That front end is in many cases far more important than the back end, punitive measures of clawback. And I think you can see from the numbers, given a program of this scale, this much budget, I'm very comfortable as your director of where we are in terms of our waste, fraud, and abuse percentages. Nothing that concerns me is overly alarming trends here.
Thank you, Mr. Chairman.
Representative Angelos.
Thank you, Mr. Chairman. Thank you, Director, for being here. During our 2025 session, there was the rate rebase had come out with the study that was done. And if my numbers are correct, it was 3.86 million per year. That's general funds, double that, because half of that would also be federal funds. So 7.72 million per biennium. Are those correct rates that is that jaunting any memory there?
Director Johansson.
Mr. Chairman, Representative Angelos, thank you for that question. A small clarification. What was discussed in the last session, I believe in both chamber floors, were certain rates that had been increased through the use of ARPA funds that were expiring. And that was the figures that you mentioned, around $3.8 million general fund, were from certain rates that had been increased by the provision of ARPA funding that came to the Department of Health following the pandemic. On the other side of that coin is the rate rebasing study that also came out in 2024. Steering committee of legislators, providers, executive branch staff ultimately recommended not to move forward with that. That rate rebasing study, much more comprehensive, is a much larger figure. I believe it was $24 million. We're using that number a lot, $24 million annually. So if you biennialize that, it would be 48 million. Half of which would be federal. And again, to reiterate, based on that rate rebasing study, there's numerous assumptions within that. Again, it's more normative, meaning where ought we to be as a state in providers being able to pay $20 an hour for a direct service professional, providing a certain level of benefits that may or may not be happening today. So two different scenarios there, Representative Angelos. Hopefully that offered some clarification.
Follow-up.
Representative Angelos.
Mr. Chairman. So just for everybody on the committee, we are talking about two separate numbers, 24 million for a rate rebasing for our providers. And then we're talking at what, 24.9 million to get everybody off the wait list. Okay, just so everybody's clear, because I think we've all been a little bit, those numbers are interchangeable since they both came in at 24 million. Appreciate that. Thank you.
Director Johansson.
Mr. Chairman,
One moment, please, Director. Go ahead, Mr. Richards.
Just because the numbers are so close, it's important that you're noting that one is a fiscal year number and the other is a biennial number. So the 24.9 is a biennial number. The 24 million for rate rebasing is an annual number.
And is it safe to say that both of those include 50% federal and 50% general funds? Okay, so we're talking 50 million in rate rebasing on a biennium and 25 million on a biennium for getting the wait list down to zero.
And Mr. Chairman, if I may, on both of those items, I want to be very clear. It is not black and white, do this or do nothing. There are options within all of those figures. So if we start with the wait list, there are options for the legislature, and we're happy to work with you, provide numbers, provide projections as we get closer to the session on what funding could look like at different scales, at graduated scales, so to speak, where you target, as the legislature did several years ago, about 3 years ago, gave the Department of Health funding and said, target funding half the people off the wait list, essentially anybody who's been waiting more than a certain amount of months. And we did that. So there's options within the wait list. There are options within the provider rate discussion of things that the legislature may want to target or work with the Department of Health to get additional information. If we funded things in certain ways, if we prioritize certain types of services, there's a lot of options with that. So I just don't want the committee to believe that the rate study, again, it's good work that happens. And providers participate in that. It's an arduous process, but it is not an either or, that either fund this or don't. There are options within that are certainly up for consideration.
All right, Senator Larson. Okay, guess we covered that. Co-chairman, please.
Okay, so I guess, can you go over with me again on the study? I thought one of the reasons the study was not complete was because of the survey. Not all surveys were sent back and we didn't have a complete picture. Maybe you can address that. And then secondly, with Director Johansson, with the comment that you just made, so clearly there's different nuances on how we can deal with the wait list, if we want to blanket it out or if we want to go. What was the level, the most severe level you were, can you give me that terminology again?
Director Johansson.
Mr. Chairman, our level of service scores range from 1 to 6, with 6 being a higher level of acuity. That happens when a slot opens up off the wait list and we notify a participant who has applied that a slot is opened up. Something called an ICAP is done, which is essentially to determine that level of service need. That happens at the point where someone is being funded off of the wait list. As we answered in the follow-up memo from Gillette, we don't do that level of service assessment when someone enters the wait list for a variety of reasons. Perhaps the most important being when we have a 12 to 18 month wait period, that situation, the acuity of the client, their particular needs can absolutely change over time and would be quite a duplicative effort to do 2 different level of service assessments, depending on when that funding would be available.
Follow up.
Thank you, Mr. Co-Chair. And then with regard to the numbers the 50 million on the provider rate, can you tell me when they came to that, was that coming up to the 2025 national standard, or was that something that simply needed to be filled? Can you talk me through what that number was? And I guess someone mentioned, is that the Ford or is that the Cadillac? I guess, can you help me out with that?
Mr. Chairman, Co-Chairman Salazar, I think one of the most important factors that drove the cost that came from the rate rebasing study, which ultimately was not recommended by the steering committee at this time, and we did not include it in our budget request last session. The most important factor was what was assumed and kind of aspirational was to be at the 75th percentile of the Bureau of Labor Statistics wage for that type of service professional. And that $20, little over $20 an hour drives a lot of that, of the assumptions in that rate model that was put forward as one of the options in that study. That's probably the biggest factor that generates those numbers is, as you saw yesterday in your tour, and as you know from Health and Human Service settings, one of the biggest components of cost in delivering services is your staffing and your wages. Certainly, indirect costs and other things go into that rate model, and we're happy to, again, provide additional tables. You have the study, but it's not light weekend reading. We're happy to provide summaries there. But that's probably the biggest assumption that drove those costs is assuming $20 an hour, essentially in that study, and a certain amount of benefit, health insurance, retirement load within those wages.
So just to be clear, Director, the $20 figure in your rate rebasing is not all inclusive. It also includes, in addition to the $20, there would be the indirect costs that Ms. Forsland brought up, as well as the benefits to those, that would be on top of the $20 per hour.
Mr. Chairman, that's correct.
Okay. Further questions for the agency? All right, trying to wrap this up quickly. I have 3 questions. I'm going to rapid fire them at you. One of the things that I find it concerning is that those people on the waiting list, we don't have a level of service assessment yet. So my question is it possible that the Extraordinary Care Commission can assign a level of service? Is that possible? What are the hurdles to accomplish that? And I'll let you answer that before I move on.
Take that.
Mr. Chairman, the Extraordinary Care Committee, it is a good question. And so my brain's whirring, trying to think of a composed answer for you. The Extraordinary Care Committee is not the group that I would direct to make that assignment. The Extraordinary Care Committee is deliberately made of Medicaid professionals outside of, or majority outside of, the waiver program administration, in order for them to have an objective view of, does the situation here meet rule or does it not? And so then the assessment that is done, the ICAP is performed by professionals in order to determine somebody's activities of daily living, instrumental activities of daily living. And so those 2 pieces aren't necessarily, again, apples to apples. We could look to trying to assign folks on the wait list a level of service score, but that would need to have an assessment element because it would be individualized and based on each individual's need rather than what the Extraordinary Care Committee considers.
Okay, I do understand that, and I understand from Director Johansson and other testimony I've received that condition can change over time as well. Fully understand that. But if this body were to determine that we were not going to do the entire waiting list funding, and we chose to prioritize a particular population as far as getting them off the waiting list, I could see that we might want to prioritize that based on level of service to relieve those families that are having to take care of these loved ones while they're on the waiting list, and getting the ones that have the most impact on families off the waiting list first. So that's what I'm trying to find a solution for. And so, Director Johansson, would you like to opine on that?
Mr. Chairman, thank you. If I may, because it's such an important topic, and I've had, again, offline discussions with a few of you on this topic, because I understand entirely what you're getting at, and it makes sense to me. If we work in a limited resource or resource constrained environment, let's take care of those most in need first. Absolutely makes sense. But give you a scenario, and this is where I struggle with going in that direction, is you have someone right now, let's say you have 2 individuals who have applied for services and have been on the wait list for 18 months. A slot opens up, we notify an individual that you are eligible for services, but the funding that we've been provided directs the department to prioritize level 5 and level 6 level of service there. So we do that assessment. The individual comes in at level 4 and we say, never mind, you're back on the wait list. It's a difficult scenario. I'm not saying it's impossible. What it requires is trade-off, that if we were to duplicate that level of service assessment, both at the beginning of the wait list and when a wait list slot opens up, it would be possible. But it comes at that, added, I think, cost from the system throughout Wyoming to say, to apply for services, you must have a level of service score and then have it done again when a slot opens up. If it's helpful, Mr. Chairman, I would just add that we are one of the only states in the region, because we want this to be efficient for not only the members, but with the funding that the legislature provides. When someone applies for services here, we do all of the financial eligibility up front, the administrative eligibility, not necessarily the clinical, activities of daily living, level of service assessment, but to make sure that we don't put people on the wait list who we know would not be eligible when a wait slot opens up. So there are some elements that we triage to make sure that we have, for lack of a better term, as comprehensive and accurate of a wait list as possible. But it's just a difficult scenario to work through of how we would handle that, because even a level 3 and level 4 service score does not mean that family with their loved one is not in dire need of some support.
Sure. I think you've illustrated my point. So I guess we kind of need to have an idea of what does it cost to do a level of service assessment? Because there's value in having that up front while somebody's on the waiting list. So if you could provide us with that in the future, maybe in our next meeting, I'd appreciate that, or beforehand. And Representative Harrelson, before I get to you, I'm going to go ahead and finish with my other 2 questions, and then I'll get to you. Are there any states that have no waiting list for the DD waiver?
Mr. Chairman, there are. Oklahoma comes to mind. That was a recent effort in the last 5 years to fund and have ongoing funding to keep the wait list at 0. There's a few states that have moved in that direction. I think we provided a few. Idaho and South Dakota are extremely, Idaho, South Dakota, North Dakota, pretty low on their wait list as well, but mixed bag in our region.
Okay. And those are all in our region too. So that's good to know. One last question. Ms. Forsland, you brought up the statutory requirement for a rebasing study every 4 years. Is that in Wyoming statute, or is that a Medicaid requirement?
Chairman, it is a Wyoming statutory requirement.
Okay, thank you. Representative Harrelson, please.
Thank you, Mr. Chairman. So kind of going back to that, the waiting list, the numbers on the waiting list, this is just because I was bored and was looking at a whole bunch of numbers. I took all of the census populations of Colorado, Idaho, Montana, Nebraska, North Dakota, South Dakota, Utah, Wyoming, and I broke them down to the number of people on DD waiver each state. Wyoming comes in second to last, actually, at 234 population for every member on the DD waiver. Only one lower is North Dakota at 158 people. But what I was looking at, I did it not for that. I did it for the fact that those that have 0 on their DD waiver waiting list, did we see a massive increase? And the truth be told, the only one that we could possibly say would be North Dakota. But if you look at it, like Idaho has a 0 waiting list, and they were at 1 to every 451 of population. So I don't know if we can, that's just more for our information. I don't think that probably stands, that we have to be concerned about us having this mass influx if we eliminate our waiver list. I don't see it statistically proving out. This is the question, though, bringing the question in. If we don't know, so we've got, right now we've got 368 or 69, I think is the updated number off that 362. If we have 368 people pursuing this and pursuing this funding, but yet we don't know what level they're at. I mean, if you look at your levels, I mean, we're talking $10,000 to $300,000. If we don't know the numbers, then how in the world can we take a $24 million number, throw that out there, and come anywhere close to hitting the target?
Mr. Chairman.
Go ahead. Director.
Thank you, Mr. Chairman. Representative Hilton, great question. The short answer is that for everybody on the wait list, our policy is that we fund those slots that come available on the supports waiver, which is basically a standardized annual budget plus medical care. And so that comes out to around $30,000 per year. What we also know, to your point, is that level of service is different for different individuals and can change over time. So the process to then transition people to the comprehensive waiver or through extraordinary care committee to additional service funding happens basically through attrition and budget availability that we manage. But for the purposes of funding the wait list, again, this is going to sound maybe more insensitive than I mean it. But I think some funding for families that are waiting at that budget amount on the supports waiver of $25,000 to $30,000 a year can be absolutely crucial for support care for their loved one, for respite care so they can go to work, so that they can take a break, home modifications, et cetera, that can happen as a result of that funding, and even care in the community through providers like you toured yesterday I think is a very important component. But you're absolutely right. Folks who get funded onto the supports waiver, there is a percentage of them who will absolutely need additional services going forward. And we do have process for that, but it's an upward pressure on the budget. And we essentially have to handle that through attrition on the waiver when slots become available and that funding becomes available.
Follow up. Thank you very much. So just as a clarifier, so everyone comes in on that support of 25 to 30,000 no matter what. And then as they get in, then we reassess their situation to the level of going, hey, this person, they're going to need $200,000 and we're going to have to see what availability budget constrictions are to make that reality. But everyone comes in at that 25 for that support waiver level.
Mr. Chairman, Representative Harrelson, that's correct.
Thank you.
Thank you. Okay, further questions for the agency? Yeah, I think we've exhausted that fairly well, and we have some follow-ups, that we'd like to get some answers during the time frame between now and our next meeting, but we're going to be continuing to look at this quite deeply. All right, moving on. We're ready for committee discussion. Is there any discussion from the members before we go to public comment? Okay. Representative Pendergraft, did you have a comment? We're going to go to that next. You're welcome to speak after public comment if you prefer. Okay. All right. We're opened up for public comment. Please come forward, introduce yourself to the public and to the committee. And we've got 4 chairs up here. So if there's more of you that would like to comment, please come forward and grab a chair. And Ms. Vaughn, do we have anyone online yet? 2 people online. Okay. Thank you. We'll do the online after the in-person public comment. Okay. Welcome to Joint Appropriations Committee here. And please introduce yourself.
My name is Bob Sell. I had an opportunity to speak to you in Gillette. As a reminder, I am the CEO of a large provider agency in Laramie, and I'm also currently the president of the Wyoming Community Service Providers Association. Do we want to introduce all of ourselves first, or?
Please, Mr. Sell, please go ahead with your testimony.
Okay. We've obviously prepared statements to address some things that happened out of the Gillette meeting. And so I think we'll cover those first, and then I'm sure you're gonna have a lot of questions for us. So we both took sort of a topic to cover. And the topic that I would like to address is that third question from the Wyoming Department of Health's memo that they sent you. And if I remember accurately, the question that was asked was, why did the rebasing steering committee not approve the study? And so what I would like to address is I feel like the steering committee did approve the study. And so I'll use their words exactly. The steering committee voted to issue this report with the rate analysis and model as presented, but it also recommended against funding the rate model. The steering committee discussed the response rate of providers of the cost study, which presented 40% of Medicaid expenditures. Department representatives determined in collaboration with Guidehouse that the response rate was adequate to continue with the rate study. The steering committee determined that the rate study should be concluded and published. And so it seems to me that there's a difference there, that there is a rate study, and I'm holding it up right here, it's right here, that was accepted and concluded. And the reason that I feel that they absolutely had to is because that's what meets the statute that we just talked about. Statute 42-4120G is the statute that requires this rate study. And so if we didn't approve the rate study, then we didn't meet the statute. So my brain, and I'm pretty simple with these things, tells me that we did. We accepted it and we approved it. We just didn't recommend funding it. And so I think that words matter, which is why I want to make sure that we are on the same page, that the study was approved and we have it in front of us. The reason that I say that is because there's basically three things that were in that statute that I think are really, really important. And the three things that are in that statute is that we have to conduct the study based on data that we collect. And this did that for sure. The second thing is that we have to establish rates that are cost-based. And the study did that as well. But there's another line in that statute that I think is really important for us to consider, which is once those new rates are established, which are in this study and were published and made available, the department shall submit a biennial supplemental budget request to adjust provider reimbursement rates. Now, I'm not a lawyer, I'm not a constitutional lawyer, I don't know, but it seems like those three things have to be met in order to meet the statute. We have to collect the data, we have to establish rates that are based on costs, and the department has to request funding for those rates. And I'm going to continue my testimony while somebody maybe really smart next to me can identify whether I'm way off base with that statute, but it seems like those three things are there, and so that money should be requested in the budget. But then there was a reason given in the Department of Health's memo that I really think is important that we talk about. And that reason was that we were trying to figure out why would the steering committee not recommend funding, and the reason they gave was the low response rate. And my problem with that is if there was too low of a response rate, then we shouldn't have accepted the data. So we accepted the data, we published the study, so that concerns me that we're now talking about a response rate. There's another comment here that really is concerning for me. It is this. Some members, and this would be the steering committee, also questioned why providers' participation in the survey wasn't higher if the need for funding was as great as the result indicated. And the reason this concerns me is to make an assumption without evidence that providers did not respond to the study because they don't need the money is not information that I think we should be talking about. It is, I think, a very dangerous statement to make. Because if we start planting the seeds in this committee and in the legislature and in the state of Wyoming that providers just simply don't need the money, then all the work that it's going to take to find the money and get people to approve it and spend it can go out the window by saying, hey, they don't actually need the money. And so I think we need to address the fact that I have two theories, other than that they don't need the money, about why this response rate was so low. And I'd like to tell you those right now. The first one is that I think it's presumptuous to assume that providers across the state of Wyoming, the 569 providers that are out there, connect the survey they were asked to complete with increased funding. I think that's a jump. Now, there are people in this room and there's folks that really pay attention to these cost surveys, and we know that there's potential that these rates will educate legislators and you might fund these rates. But providers around the state, I don't think make that connection. They're asked to complete a cost study. And here it is. I printed it for you. This survey. This is like over 50 pages long of Excel spreadsheets that they're asked to complete. And when they're asked to complete this study, they're not told it has anything to do with money. It says it's going to educate people on what the rates could be. I will also tell you two other examples of why I don't think this is true. If we are fortunate enough to get rate increases out of this conversation we're having, those rate increases will go into effect on July 1st, 2026, a full 2.5 years after providers were asked to fill out the survey. And for us to assume that they know their survey is going to somehow end up with money, I think is a stretch for me. Plus, what we know is all rate increases we have seen, at least in the last 20 years, have come out of the legislature. And we don't talk about increasing the rates based on the cost study. We talk about putting money into a system to make it more solvent, to make sure that individuals have the level of service that they need. And we say, there's money available. And then when we hear it back as providers, We're just told, oh, they approved more money. Here are your new rates. And I can't find anything in any correspondence from the legislature or from the Department of Health that says the rates that you're now being paid are directly related to the cost study that we completed and the survey you completed. I will also point out one other thing, which is when these rates, and it's another thing, just more evidence of this for me, is when this study was published and sent out to all the providers to look at, the Wyoming Department of Health's memo says the department would like to thank the service providers and stakeholders that participated in this project. The input received from the stakeholders over the course of the project was key in delivering an accurate and high-quality rate study. So my testimony is that I think providers know that the survey turns into a study, but I don't see the connection to money, which is one reason why I think that the response rate was low. And certainly not because they don't need the money. I think that's a stretch to make. And the second reason that I would like to bring to your attention about why this response rate was low, which obviously led to the steering committee not recommending funding, was an actual error in the study itself, in the survey, an actual error on the instructions in the survey that, in my opinion, basically told providers not to fill it out. The Wyoming Department of Health sent 3 emails out asking us to complete this survey. The first 2 were basically the same. There's a link. Please fill out this rate study by Friday, January 26th. This one came out on December 11, 2023. There's a link to short study, and there's a link to full study for providers earning $1 million or more. And then another memo came out January 4th, basically with the same information. Click on the link, fill out the study. When you open up this survey and you click on short study, first thing I'm going to do is read the instructions. And these instructions say, and I will read them to you exactly as they were when providers looked at it. This survey should be completed by waiver providers with $1 million or more in waiver revenue. Providers earning less than $1 million are asked to fill out a separate survey, but are welcome to fill out the full survey. So if I have less than $1 million in waiver funding, I do not believe this is my survey. That's how I would interpret it. Because it says providers less than $1 million are asked to fill out a separate survey. So I don't know, was that 5%, 10%, 20% of people who would have filled it out but didn't? The Wyoming Department of Health did try to correct the error because another email came out. And this one came out on January 29, 2024, 3 days after the closing date of the survey. This one says, due to the low response rate, the survey deadline has been extended to this Friday, February 2nd. So this came out at 4:10, so about 4 days more to complete the survey. But now there's some new information on this. Next to the link to the short survey, it now says for providers earning less than $1 million. And it says, please note, the short survey contains a typo about providers earning $1 million or more not completing the survey. This is a survey error. Please complete the survey. Problem is, the definition of the problem is not the actual problem, right? Because this says providers earning $1 million or more not completing the survey. This says the survey should be completed by providers earning $1 million or more. And providers earning less than $1 million should fill out a separate survey. I don't think this was this was a total mistake. The reason being is because the instructions on the short survey are just the exact same instructions that are on the full survey. So somehow they just got placed on the same survey. I don't believe that providers didn't want to fill out the survey because they don't have needs. I believe that there are a lot of reasons why. And I think that if we're going to make a judgment about why there was a response rate and make a judgment about not recommending funding based on that response rate, there should have been some research done into why the response rate was so low. So I think there's a lot of data out there that points to why the response rate was too low. And I don't think blaming the providers is the way to go. So what I would like to just kind of finish off my part of this for is this. We have a lot of speculation that happens around this cost survey, and a lot of speculation about why we did what and who did what, and what I would like to do is maybe put all that to rest. I would like us to stop asking questions about the survey itself, stop asking questions about response rates because we have the survey. And I like to deal with facts. The world that I am in, the service I provide is full of tons of unpredictability and inconsistencies and differing opinions and lots of emotions. So if I have an opportunity to make a decision based on fact, that's what I will do. And I think you have 3 facts that are right there in front of you that I think we should focus on. 1, we have a rate study that is valid and accurate indicator of the costs of providing services on July 1st, 2026. It's right there. Either we accept it or we don't. We paid $226,000 to get it. So I think we should accept it as a fact and we should use it. The second fact then is the rates that are identified in this, you guys were asking about rates, they are actually put in here of what they are now and what they would be if you implemented this study. What I'm going to tell you is if a provider in the state of Wyoming after July 1st, 2026 chooses to provide one of these rates, they need to be compensated at this rate. If they're not, I think we can assume they are not going to be able to cover costs because these rates are based on costs. And the last fact I have for you is that Guidehouse said that they estimate that the cost to implement this study is going to be $12 million a year. That's what it says. So let's stop fighting the study and let's just try to figure out how we're going to fund this thing or choose not to. That's my choice. Either we choose not to fund it or we choose to fund it. As the Department of Health said, there's lots and lots of options. And I agree, there are a lot of options. But the study's there. You paid $226,000 for it, and it tells you exactly what the rate should be to cover costs. So I think we should start looking at why we're not just trying to fund this study. That's my test.
Thank you, Mr. Sell. Questions for Mr. Sell?
Mr. Chairman.
Go ahead, Representative Haroldson.
Thank you, Mr. Chairman. Thank you for coming and coming up from Albany County and allowing me to be here today. So kind of what you're saying, and I just want to clarify because I didn't fully understand that last little statement where you're like, fund the study or don't fund it. So you're saying you pretty much want the 50 million or don't even worry about it.
Nope, that's not what I mean.
Chair,
Thank you
please,
for giving me,
Mr. Sell.
sorry, Mr. Chairman. To clarify my comment is, what I don't want is there to be this speculation out there that let's not fund providers or help increase provider rates because providers don't need the money. Let's not fund provider rates because the response rate was low. What I want to do is be able to look each other in the eye and say, here is what it costs to fund it and make choices of whether we're going to or not, and fund it completely, fund it partially, choose not to fund it at all. But at least then we're dealing with actual data that's driving our decision-making instead of trying to fund some other way. Like I said, we had this in the past where we had concrete data, but then the word got out. It was like, well, maybe providers don't need money. And then we even had the conversation at our last meeting that said, well, let's let providers start proving they need the money. Well, you got 569 providers out there that don't just do this. I have a funding source in DVR. I have contracts with the Albany County School District. I rent property to my clients that pay rent. And so there's a lot of things that go into me showing you my financials. What I would prefer is that we all use the fact that you already paid to find out what the need was. And that's why we'd like to focus on it.
I think this committee is taking this very seriously, whether the recommendation of the report was followed by the department or not. We have taken this up, studied it. We are taking it very seriously what that provider rate should be and whether we're going to fund it to a certain level or not. So we're here to hear that testimony from you, and we appreciate it. But we're going to take this very seriously.
Would you mind if I just commented on
Go
that?
ahead, Mr. Sell.
I want to just finish before I turn it over to my colleague that after the testimony that I gave in Gillette, I received a lot of comments from families showing their appreciation for what I did in my testimony. What I think you should also hear based on what you said, Mr. Chair, is they also wanted me to pass on our appreciation to you because family members of folks with developmental disabilities often do not feel heard. They have to battle for everything that they can get. Mm-hmm. And what they're telling me is no matter what the outcome of this is, they're feeling heard right now. And so I wanted to pass that on to you.
Thank you. That's exceptional for this committee to hear that, and we appreciate your being a voice for them. Okay. Thank you. Welcome to House Appropriations. Before you introduce yourself, do we have a follow-up?
Thank you, Mr. Chairman. I think something that needs to be addressed yesterday when we took that tour, and we were talking about entry wages, average wages. And I think that was a situation as we were looking at these amazing people that we get to work, that you guys get to work with every day, that these individuals get to work with every day. And the fact that their entry wage is $15 an hour. I can go flip burgers for more than $15 an hour. I mean, and I think those are the understandings. And I think, let's face it, the inflation and all of the things that we're dealing with in the country right now, those are things we're dealing with. But because of that, we want the best possible people to work with these amazing people. And part of that, I mean, I know money isn't everything and it should never be everything, but there's also a point where simple economics have to come into the homes of these workers of going, hey, I can't put food on the table. I can't pay my bills. And so that's where we have to have those conversations. So I think that just respectfully to push back a little bit, we realize that and we care about that. And we want the best options to move forward for those in our communities that have had accidents or had these bad situations happen to them. So, so I definitely, and I'm sorry that the survey went the way it did. But I'll also say the survey did go the way it did, and now let's worry about making sure that these people aren't paid $15 an hour to do this work. That's, I think, more than anything. We can put all the rest of that aside and say we definitely need to address some things.
All right. Thank you. Ma'am, if you'd like to introduce yourself to oh, I'm sorry. Senator Larson had a.
Thank you, Mr. Chairman. I want to reiterate that, yes, we are very concerned. And doing the tour yesterday is eye-opening. Anytime we go there to that type of facilities, obviously. So you have our attention. I wanted to ask, do you have an association where you kind of gather annually? And if you do, does the comments from the association go to the director? And I would guess they do, but maybe they could come our direction too, but we are listening.
Mr. Chair, yeah, absolutely. In fact, I'm currently serving as the president of that association, the Wyoming Community Providers Association, and my colleague Jeff Gardner at the end down there is our executive director. And when he gets a chance to speak, I think he can address how we share comments. I will tell you that I don't usually. Some of you saw me do this in Gillette. There are times where I'm representing the association and sometimes where I speak for myself. And so that can be challenging. But I just want to say that absolutely, I hope I wasn't misunderstood in my testimony, which is I appreciate what you're trying to do. I just want to make sure all the information's on the table about where we are as far as the information we have. So I don't know if you want to just continue.
Okay, follow up, Mr. Representative Larson, I'm sorry, Senator Larson.
Mr. Co-Chairman, thank you. Do the smaller providers go to these meetings, I guess, would be a question I'd have. Or is it usually just the larger ones?
All right, before, if you're going to respond to that, I want to get to the young lady here, but so if you can hold on to your question, we'll ask it again. It looks like he's going to respond to that. Mr. Co-Chair, your question for Mr. Sell?
Yeah, Mr. Sell, first of all, thank you for being here. I didn't take any of your comments to be negative.
Oh, thank you.
And so, but I will say this. I don't know when the Joint Appropriations Committee has spent more time on the DD waiver than now.
Yep.
So to those, and the Department of Health has many programs, the blind, the deaf, mental health. We can go through all that. This committee has spent last meeting, this meeting, we're going really in depth on one issue, DD waiver.
Mm-hmm.
I don't know if that will happen again for years to come, but clearly this committee has a great interest in the DD waiver and fixing it, reducing the wait time, the waiting list, and obviously looking at the rates. And so to those families, I would simply say, we're going to address it. We're addressing it now. We've addressed it for 2 meetings, which is quite something for the Joint Appropriations Committee on this issue. So there's hope. There's hope for those families. And I feel good about the DD waiver. We're going to come to a conclusion on this issue. And there are a number of discussions going on right now. So I would simply say to those families, we're taking the time to do it right. And I think that we are going to make progress in this specific area, DD waivers. Thank you, Mr.
All right, thank you. Ma'am, I've been trying to get to you, so here we are. Here's your opportunity. Please
Thank
introduce
you, Mr.
yourself.
Chairman and members of the committee. My name is Tina Conley. I am the Executive Director of iReach 2 in Casper. We are serving 43 amazing, incredible human beings, and we've been doing that for just over 25 years. My purpose today, and Director Johansson did most of the legwork on my topic, and that is to talk about how structurally sound our system is in terms of waste, fraud, abuse, and corruption. So I appreciate the director already providing you with that. In addition to my role as an executive director, I am also a peer surveyor for CARF. CARF is an international accrediting body. That in the state of Wyoming, Chapter 45 of Medicaid mandates anybody that is over $150,000 in revenue has to get a national accreditation. So I go and travel the country and do these accreditation surveys with CARF. On average, we're going to rate over 1,000 standards in a CARF survey. And in Wyoming specifically, providers are required to have the comprehensive, the certification process and recertification process that happens anywhere between once every 3 years to every other year, depending on what the state determines. CARF is also every 3 years, sometimes every year, and sometimes CARF will call the state and say this is a non-accred situation. It's very, very rare in our state. I'm a little nervous. I've never done this before, so.
Please don't
Yeah,
be. You're doing
The other
great.
thing that within our regulatory framework is a detailed service plan that outlines what the individual services are going to be and a complex structure of service definitions and how you bill services. And this layers of, eyes and regulatory agencies looking over us at all times. I'm a rule follower, so I love it. I love the Medicaid rules. I love CARF. Gives me a lot of comfort to follow the rules, and I take comfort in that our system is in good shape. We have ongoing audits. We both within the state and fiscal audits. We have to be verifying through the Office of the Inspector General the backgrounds on people. So we aren't hiring people who have committed Medicaid fraud in another state. We have mandatory reporting, training, and compliance tracking systems for a variety of things. Managing risk, managing our strategic initiatives, managing our staff, ongoing health and safety training. And each of these safeguards are in place to protect the health, safety, and welfare of the people we serve. For me, the rules are all about protecting the people that we serve so they are living their best life in their home communities. The Department of Health collaborates with CMS and gets that guidance from CMS with what's they're going to approve and what that looks like. So when this rears its ugly head, that this suggestion that our system is just wrought with all of these corruption and we're all driving around in Range Rovers, I'll meet you out in the parking lot with my 12-year-old Explorer. So that's really all I wanted to say, and I would stand for any questions.
All right, Ms. Connolly, thank you for being here, and I appreciate your testimony because that answers a lot of questions about the providers when you explain that. I do have one question, I think there's a bifurcation of those providers that are over a certain dollar amount, but we heard testimony from the agency that there's somewhere between 500 and 600 providers in the state, and many of those are one, two, or three people that they're providing for. And so how does how does CARF apply to those small providers?
Well, it wouldn't be out of the realm of possibility if I was serving as an independent provider, 2 people, and they were in residential services, I'm going to already be at that $150,000 threshold pretty quickly. So, that would be more of a Department of Health question about how many people are actually getting their accreditation. I just know that it is a rigorous process. If there's folks in Casper, and most of my colleagues in Casper know I'm a surveyor, they will call me up and, get guidance on what should I do. And I think that's the other great thing about the network of supports we have in our state is the level of collaboration that happens there.
Well, I'm grateful for one, that there are rule followers like yourself out there. I'm not one of those, so I appreciate you very much. Are there any further questions for Ms. Connolly? All right, seeing none, we'll move on. Thank you very much for being here. And thank you, sir, for being here. Please introduce yourself.
There's the green. Thank you, Mr. Chairman. My name is Jeff Gardner, and as excuse me, as Bob said, I'm the executive director of the Wyoming Community Service Providers. My intent today was to address the differences between the cost study and the waiting list, which I think has been really well understood by the committee. But before I get into anything I'm going to say, in echoing Co-Chairman Salazar's comments just a little bit ago, I, for one, really understand and appreciate the fact that you have taken this up as an interim topic, and I'm grateful for the acknowledgement of the importance of what we do. I've been working in this field with and for people with intellectual disabilities now for 36 years. I've been in this role for 10, and I agree, Mr. Co-Chairman, that I've not seen this level of commitment or discussion relative to people with intellectual and developmental disabilities particularly from the Appropriations Committee. So I appreciate that very much. If I could, Mr. Chairman, I would like to address some things that have already come up. One being, and I'm not going to talk about this for long because as I just said, I think it's very well understood the difference between the cost study and the waiting list. The waiting list, certainly no provider, certainly not within our membership, is going to say that people who are waiting for services are not as important, that we need to try and get those folks the support and the help that they need. But that doesn't work if that is solely the focus. There has to be consideration, and I know that there is, to fund the costs. The study that was published is cost-based, and I'm repeating, but I think it's important to reinforce those are actual costs. And the foundation of those rates are direct support wages. Those folks that you met yesterday, those of you who were on the tour, and thank you for doing that. It was, I hope, a great experience for you. But those folks that you met yesterday that, start at $15 an hour, not enough, which has been well established, but that is the foundation of the rates. So looking at those direct costs, or as Ms. Forsland said, the direct service costs, that is based on that wage and then built up from there. So I think it's clear. I won't belabor those points. I did say to the committee yesterday during your tour, and I will reiterate, I believe this last cost study is, I believe, the 5th since that statute was put in place. One time in 2018, it was funded completely. And we told the legislature and the Appropriations Committee at the time that if you fully fund this cost study, you won't hear from us for 3 years. that this current study is based with an inflationary factor of I believe it was 4.3 through 2027. So if this is funded in full, you won't hear from us until, I guess, the budget session of 27. A couple of more things. I wanted to, I guess, respond to Senator Larson's question about small providers. Our association is very open to that. We have providers ranging from, you know, a few $100,000 a year in waiver revenue up to around 10 million, as you heard yesterday from the community entry services. We do know that we need to do some better, you know, outreach and marketing. We would love to have the perspective of those smaller providers. I don't know that we have, you know, someone serving one or two people. I don't know. I think they would find benefit in our association, but certainly, again, to your question we're open to those folks, to those small providers. Just a little bit of history, and I won't take much time. The Wyoming Community Service Providers was actually incorporated in 1976 as, I don't even remember the original name, but we've gone through, what was it? No, that was the second one. It was, yeah. Anyway, so we're in our third iteration of names, but, and back in those days, Wyoming was based on a geographic system, meaning that if you lived in Casper in those days, you would have received services at NowCap or iReach 2. If you lived in Laramie, you would have received services from ARC and so forth. And then in 1991, when the waiver came along, one of the first things that the state has to agree to, which we agree with as well, is choice of providers. So that's when the provider system really started to explode into what's now 500 and some odd, you know, providers. So with that, certainly stand for any questions, Mr. Chairman. And again, just one more, you know, I guess, expression of gratitude for your commitment to this, and we see it. So thank you.
Thank you, Mr. Gardner. Senator Larson.
Yes, Mr. Chairman, I have to apologize. I knew there was an association. I guess my biggest question is the small providers, if they're kind of part of it, and hopefully they're watching and maybe they'll join. So I'm sure their input in your association is vital.
Mr. Gardner.
Thank you, Mr. Chairman. Senator Larson, yeah, we have done a few more things to try and reach out to those folks, you know, via Facebook and posting to other, you know, Facebook pages that are specific to people with intellectual and developmental disabilities. So I hope so too. Thank you.
Further questions? Just one moment. Further questions for Mr. Gardner? Okay, Mr. Sell, please.
I just wanted to add that we do, within our communities, we do have relationships with those small providers that you're talking about. And so I wanted to add to that a lot of them will reach out to me and just say, you know, what happened at your last meeting? What are the issues that you're up against? Because if you think about a provider that is serving, as we said, like 3 people, they're working all the time. I mean, they're providing direct care. They're also doing the billing. They're doing everything. So our outreach outside of the association, I think, is pretty broad, because we have a social gathering in Laramie where all the providers are welcome to join. And we say, why don't you join the association? And there's a lot of reasons why they don't, but I think they are participating in ways that aren't obvious and upfront. And I think that it is important to know that we are working, that the providers across the state work together. We communicate together. We share best practices. And I think that's all part of what you're, I think, asking about.
Okay. Thank you. I think we're ready to move to online. Is there anyone else in the room that cares to opine on this particular bill? Okay, seeing none, we'll go ahead and move to online. Ms. Vaughn, would you please let us know who we've got coming online? Do we still have 2?
Yes, sir. We have Mr. Sweeney and Miss Cummings. They're both in the rooms, and we take them in
Okay.
any order you choose.
All right, let's start with Ms. Cummings. Ms. Cummings, welcome to Joint Appropriations Committee.
Thank you, Mr. Chairman.
Please introduce
My name
yourself.
is Jolene Cummings, and I am here representing my son, who is an individual with a cognitive disability. He's been on the waiver services for about 9 years, and he is on the supports waiver. I can honestly speak that from a parent's point of view, the cost rebate really needs to go into effect, or the cost study needs to go into effect. I currently juggle with his current budget with trying to figure out, am I going to give him more money to be able to have supports while he's working on his employment? Or am I going to give him supports to be able to stay in his home and live independently with him on his own? I constantly hear from support workers, not just only where he is supported at, but throughout some of my colleagues and other family members, that support service workers right now are very short in supply. They can't make a living working where they're at. Sometimes they're working 2 to 3 jobs, including working as a direct support professional. And my fear is if we don't put this in, that we are not going to be able to keep any support workers, let alone fund people off the waiver. So if you are talking about the wait list, and we fund those individuals, if we keep our direct support professionals at the same rate that they're making now, how are we going to have enough direct support professionals to support those people that are coming off the wait list? So I just wanted to come up and voice my opinion on this and share with you that some of our concerns and the fears that we're having as parents, trying to keep our individuals in the system with the current cost rate. Thank you for your time.
Thank you for being here, Ms. Cummings. Do we have any questions or comments for Ms. Cummings from the body? Okay. Again, we appreciate that. Before we get to Mr. Sweeney, I just recognize that we have Representative Ottman here. Representative Ottman, would you please come forward? And while we're waiting on that, we'll go ahead and get to Mr. Sweeney.
Thank you, Mr. Chairman, for allowing me, Pat Sweeney from Casper. So my first 4 years in the legislature was, one of my assignments was on the health and labor. And so we've this is a very complicated subject, as you can already see for the new members of Appropriations. And I believe it's been dealt with forever. And so on the provider rates, money, I hate to disagree with the chairman, but money does matter. And you're absolutely correct. You got to have a passion for the work, but money is very important in the whole process of this for the caretakers to the contract for this kind of work, to continue to be able to hire folks and the state to fund this. And I think the department does a tremendous job with all of these programs, and this one in particular. And I think you can just look to the school districts on the western portion of the state, because I've heard testimony just the opposite of the numbers that the Representative Haraldson mentioned, which I don't dispute the numbers, but you can talk to folks on the western side where we heard testimony that folks moved to Wyoming in a particular school district on the waiver program. And I can't remember the specific school district, but at that time, just to take care of and quote unquote educate that child was well over $250,000, putting that school district way behind. And so I agree, we can't come up with the funds to get everybody off the waiver. So we need, or off the waiting list, but we've got to be careful on that also. And so where do we find the funds? How do we make this all work? And I'll tell you, just last weekend or the weekend before, I attended a fundraiser for one of the case in points is iReach, is a provider here in Casper. And when I was in the legislature, directly worked with a lot of our providers in Casper, in particular, trying to figure out the rebasing, trying to figure out all of these different things while I was on labor health, and then even when my last 2 years not on labor health. But so I attended her fundraiser. That is a way they can raise funds separately. And she has a successful track record of raising funds, but it depends on the community being able to support that. But I urge you to take a look at this. In one of the other comments by one of the other committee members was, for the department to find the funds internally, and not raise the appropriation. I can tell you firsthand that's not going to work. And it's a great goal, and the churches will help, and local communities. The churches and local communities are doing all they can in lots of arenas, but in particular, the local communities are stepping up where they can. And with local folks, not necessarily the government, city of Casper. But with that, I just urge you to keep an open mind on this funding, and it is complicated. I appreciate your work in allowing me to testify remotely. Thank you.
Thank you, Mr. Sweeney. Comments from Mr. Sweeney? Seeing none, we'll go on to Representative Ottman. Thank you for being here, Representative.
Yes, thank you, Mr. Chairman, Mr. Co-Chairman, and committee. It's so good to see you. Welcome to House District 34. It's wonderful to welcome you here. I was glad Mayor Nouveau was here. And while I wasn't here in person for a while, I was on Zoom. So I appreciate all the wonderful work that you're doing. I just wanted to say that this is an important topic for sure. As a young person, I worked with the developmentally disabled, and it takes a certain mindset to be able to do that work. Not everybody can do it. And I think a lot of people don't understand what it entails. When you're taking care of people, that it goes back to sometimes the very basic of services for those that cannot care for themselves, up through those that just need some help to go to work, to go to school, and whatever. You don't really get prepared in college to do those jobs. You just don't. And while in the 50s, 60s, 70s, a lot of people would go into those situations, we don't see that as often anymore. So while pay scale is definitely important, and $15 an hour these days is not a lot. I will say is that to get people educated into the type of work this is and to hit that is imperative, because some people, it doesn't matter if you paid them $50 an hour, they could not do this job. So I would just leave you with that. Also, I want to say is thank you for all the work that you're doing on the many, many topics. And to go along with the DD, we have here in Fremont County, the CES Community Entry Services as a fundraiser, and it's called Dancing with the Stars. And I would challenge each one of you who are so burdened about this effort to volunteer to be participants in that this year. So anyway, with that, I would stand for any questions. And again, thank you for being here and the work you do.
Well, Representative Ottman, you have definitely not seen me dance, so probably won't anytime soon. Questions or comments for the good representative? Seeing none, Representative, we really appreciate your stopping by, and you have a beautiful district. Thank you.
Yes, thank you.
Okay, Ms. Vaughn, do we have anyone else online? All right, so concluding public comment, we'll move on. And now we're in the section of our schedule and agenda for committee directives. So I'm going to open it up to the committee for any directives for our staff. Any directives for our staff? Representative Pendergraft.
Thank you, Mr. Chairman. Whereas the Department of Health, the Wyoming Department of Health, has a larger total budget, about $2.25 billion, than any other agency other than K-12, which, by the way, is undergoing considerable evaluation and recalibration this interim. Although the Department of Health's general fund budget has grown modestly, approximately $30 million in the last decade, the agency has benefited from considerable one-time federal funding during the pandemic. Whereas even modest percentage increases to such a large agency's budget can have significant impact on total state budget needs, the Department of Health's budget has an outsized impact on Wyoming's total budget. Whereas this committee has expressed interest in supporting specific initiatives such as the waiting list of persons with developmental disabilities and desires to find the necessary funds for implementation within the current Department of Health budget. Therefore, continued aggressive legislative oversight, I believe, and attention is warranted. That having been said, I move that the JAC create a subcommittee of 3 members consisting of 2 Republican and 1 Democrat member of the JAC to conduct a deeper investigation and analysis of the Department of Health's budget for the upcoming 27-28 biennium. Membership should be determined by the co-chairs, and the co-chair shall request funding for up to 2 in-person. This would, of course, provide for public comment, and 3 virtual meetings prior to the JAC's December meeting. The purpose of this subcommittee is to provide a well-reasoned, sustainable recommendation for the JAC to properly position Wyoming's Department of Health for long-term success.
Do I have a second? Representative Sherwood.
I'll second for discussion.
Okay. So we'll open this up for discussion. You've heard the motion. Any discussion from the committee? Representative Sherwood.
Thank you, Mr. Chairman. And I think I've shared this with some of you individually. In looking at the Department of Health, my biggest concern is where cuts to federal resources are going to impact their mission and what that looks like in our communities in terms of to our service providers. So I'm some nuance in that motion and just the importance of understanding where a reduction in federal services is going to impact the overall Department of Health's budget. Thank you, Mr. Chairman.
Okay. Before I get to you, I'm just going to comment on that, Representative Pendergraft. So we've heard testimony that we're going to see an influx of funds for rural health. And so that should also be taken into account, federal funding increases. And so that's why I think it's a good idea that we have this motion on the table for a subcommittee to do a deep dive. We did hear testimony from the agency that they're in the midst of working on their budget. So I hope that we can get the agency to be involved with this subcommittee should the co-chair and I get approval for funding for the subcommittee. So Representative Pendergraft.
Thank you, Mr. Chairman. I just want to remind the folks that are here why we're wearing red. And that is, we see an impending problem with the state budget. And it would be nice just to be able to stand out and hand out whatever money was needed, wherever it was. But if it's not there, it's not there. And anything that we do needs to be done with as much information and input and knowledge as is humanly possible. And that's why we've given it the time during the interim. That's why I would like to have a subcommittee that could really delve into this, to work with the agencies involved and to really understand what it is we're doing, because anything we do will impact people. As you pointed out, the vast majority of your budget goes directly out to people. And so we've got to take a hard look at that. And whatever we do is going to be a very difficult decision and needs to be made with gravity and caution. And I just want to assure everybody that I have complete understanding of the magnitude of what it is we're looking at.
Okay, well, thank you for that comment, Representative Pendergraft. I think the motion on the table, is there any further discussion, first of all, in the committee? So the motion on the table is to assign a subcommittee to look at the Department of Health's budget, in particular the programs that will be carried into the next biennium. And there's directions in this motion for the co-chairs to assign members and to seek funding from the Management Council for this subcommittee. The motion is for 5 meetings, 2 in person, 3 via Zoom. And I think from previous discussions with my co-chair, if we're going to go forward with this just to, as a matter of information for the body before you vote, most likely we found that the cost savings would be most found on those in-person meetings if we held them in Casper. So the intent would be to have 2 meetings in Casper, probably the first and last, and then 3 Zoom meetings to accomplish this very daunting task, and it would be 3 members. So any questions or comments before we vote? Okay, the motion's on the table. No further comments. All those in favor of the motion, say aye. All those opposed? And I didn't see your lips moving there, Senator Grew. Or can you just tell me your position on this?
I'm sorry, Mr. Chairman, I'm a no. Thank you.
Okay. So the motion carries, and co-chair, we'll go ahead and take action that we need to on this. And thank you for the motion. Are there any other items that the committee would like to discuss for directives? Seeing none, I think we're ready to adjourn. All right. This meeting is adjourned. Thank you, everyone. You okay? Yeah. Got a frown on your face. No.